Hello and welcome to this discussion today. The title of the discussion is The Pandemic and Violence Against Women with Disabilities, Communities and Inclusion. I'm Nandini Ghosh from the Institute of Development Studies, Kolkata. We are going to be discussing, as the topic suggests, how the pandemic has affected the lives of women with disabilities in India, within the families and communities, how violence has foreclosed all chances of inclusion which was tenuous at any point of time. Women with disabilities are one of the most vulnerable and invisible sections in India, as we know. According to the 2011 census, uh, we had a 2.21% of India's total population that was disabled, and women with disabilities constitute 44% of this total population. However, WHO and other estimates have shown that on an average, roughly 19.2% of women with disabilities are there across the globe. Due to their gender and disability, women with disabilities face multiple discriminations in the domains of culture, society, politics, and the economy. During COVID-19 pandemic and the subsequent disruption of lives, all people across groups were badly affected. But for women with disabilities who were already dependent on their families physically, financially, and emotionally, this has been a catastrophic situation. It has had an effect on their personal mobility and freedom. It has affected their access to medical and rehabilitation facilities. It has resulted in losing of livelihoods and being exposed to violence within families and communities. So if you look at Article 19 of the UNCRPD, which talks about living independently and being included in the community, in a way has been severely affected during this pandemic. And today this discussion is going to look at lives of women with disabilities during the pandemic and try to understand ways in which existing forms of violence have been exacerbated by the COVID-19 disruptions, lockdowns, and socio-economic slowdown. We have three people on the discussion today. We have with us Ms. Reena Mohanty, who is the convener of the Women with Disabilities India Network. She works with Shanta Memorial Rehabilitation Centre as program head and has a master's degree in women's studies and is currently doing a PhD on issues of women with disabilities. Reena works with women with disabilities across India and especially using human rights mechanisms. She has written on women with disabilities, especially during disasters, and she will be presenting today a study that was conducted during the pandemic with women with disabilities to understand their major concerns. We also have with us Professor Renu Adlakha, who's a professor at the Center for Women's Development Studies, which is a ICSSR recognized institute. She's presently engaged in research on health, disability, gender, and development, and she's published widely in national and international peer-reviewed journals. Uh, the, she has a lot of books to her credit, but the latest book that is there is a volume called Disability Studies in India, the Global Discourses, Local Realities, which came out in 2013. And our third speaker for the day would be Ms. Nidhi Goyal, who is a disabled feminist activist from India working on disability rights and gender justice. She's committed to changing the lives of persons with disabilities, particularly women and girls. Nidhi has her own Mumbai-based NGO called Rising Flame, which works mainly in the area of sexuality, gender, health, and rights for women and girls with disabilities. And Nidhi is widely represented across a lot of decision-making bodies, both in India and in the international scenario. So, having this eminent panel, I will now like to request Reena to talk about the study that Women with Disabilities India Network and SMRC conducted during the pandemic to understand the major issues that were faced by women with disabilities during this time.
I would like to now speak on the study which we did on COVID-19 and the impact it had on women of disabilities in India. And this COVID-19 was started in China in the last quarter of 2019, and then on 11th March 2020, WHO confirmed the first case in India. And then COVID-19 came as a crisis and became pandemic very soon by affecting millions of people in 216 countries. Women with disabilities. In India, a large group of disabled population is there, and 11.8 million women with disabilities in India who experience considerable difficulties in everyday life, such as high poverty level, poor health conditions, lower income, lower education, and patriarchal system also increased in further endangering in COVID-19. Assess the situation, SMRC came to know they realized that data from the field had to be collected and analyzed. Understanding that the issues was of most importance. SMRC could ensure participation of women with disability in all our work. Pay attention, we do not miss out on the intersectional ties of disability and include women of all classes, that is indigenous women like the Adivasi, the Dalits, etc. Collection of data was done by our state coordinators and the field workers who got in touch with the women from the project field telephonically. Use the Women with Disability India network was also helped to collect data from other states. Information what we collected was that 80% of the women with disabilities in these three states had not access to public information from government sources. Media reporting was inaccessible. Their source of information were SMRs was only SMRC field staff, the family and their family and the frontline workers in the village. In most cases, no one thought it important to convey word of mouth information. Then social distancing was a very important way to avoid this virus. The women with disability, it is not possible as women are dependent on personal attendance and cannot maintain the distance required. Though 90% had carers from within the family and they all lived as usually in one or minimum two rooms. 10% of the personal assistants were missing because they were not getting permission to come due to the lockdown. Then food insecurity. Grocery shops are open for a limited period. Access to one meal a day, limited stock at home and shared by many. In Orissa, 90% of the women with disability had low access to food. Gujarat food insecurity continues and 80% of the women had no access to food. Their health was a big issue. Women with disability were unable to go to hospital without a pass as they could not go to the police station for a pass. Pregnant women were not attended by a doctor, for which one of the women lost her baby. Miscarriage due to not attended by the doctors in the 6 months of pregnancy. Lack of medicine during the lockdown time. Telemedicine services was not functioning. Government, especially the government ones, and private ones were very high cost. Then violence increased during the lockdown period. Increase in violence from partners and family members as stress level within the household. Verbal abuse was 80%, economic violence 90%, battering in 30% cases. Psychological stress had also increased. Depression was high, no counseling session. Homelessness, women have faced abuse and asked to leave home, as well as lockdown. With all the lockdowns, all men members had returned home. Then livelihood and social protection was also one big issue. No income, economic activities were closed, loss of wage, no job, no work. 80% of the women lost their wages. 10% of the women with disabilities, those who were busy with vegetable growing, could not sell their products. 100% lost in garment making and handicraft entrepreneurship. The 1,000 rupees promised by the government has yet to reach some of them, and the ones that do not have a bank account were deprived of the money. The nearby ATMs do not have money and they needed support to go to their bank to withdraw. Moreover, the police stopped them at every step and the family avoided taking them to the banks. Migrants, women with disabilities, 100% visual impaired was not allowed by the villagers to return home in Orissa. In Gujarat, one family was quarantined, was traveled to Delhi, and the quarantine centers, and the toilets were not accessible. Women living independent do not have access to fetch groceries from the market. Online order cannot be made as it's not available everywhere. Many were dependent on home delivery. Then protection measures were not available, like no sanitizers, disinfectants, hand washing, soap, masks. Lack of adequate water for sanitation, sanitary napkins were not also available. No smartphone for the education.
I'm sorry, Nandini ma'am, you're on mute actually. Yeah, sorry to.
Thank you. Okay, so thank you, Reena, for those comments. The report of the study very clearly, I think, 2 points come out. One is the different kinds of violence that women with disabilities face, but also the fact that the intersectionality that you have looked at, not only in terms of gender and disability, but also in terms of the other identities that the women have. So, migrant women with disabilities, and looking at, say, Dalit women with disabilities, tribal women with disabilities, and how their lives were affected during the pandemic situation, the lockdowns, etc. I would like to invite now Renu to talk about the different forms of violence that the structural violence within the communities that really affect choices of independent living for women with disabilities. I know independent living in India, in our cultural scenario itself, is a little bit of problematic, and for women with disabilities, it's even more so. So during the pandemic, how did the social institutions and community structures impinge on living safely within communities for women with disabilities? Renu?
Yeah. So thank you, Nandini. Thank you, Reena, for giving this overview. Though the study was in the context of Orissa, I think it has pan-Indian implications. And even though it was telephone-based, I think it really captured the reality. And, just as an aside, because I'm a researcher, I'm actually I know it's the only means of doing research in terms of data collection during this period, but online, does not capture even half the reality that we often that exists. And online surveys, I find, are, even the research process itself is a bit problematic, because you don't capture the inherent reality. It's through a medium, and it's mediated by not only technology but the way that the people want to talk. You don't have the whole context to frame your research ideas, but this is what most of us are doing at this point, and I really look forward to a time when we don't have to do just this method of research. So that's just one thing. So I'm going to actually taking off from Reena's presentation of the study and talking about it in the context of uh, very middle, low-income families, women in those contexts. I'm going to actually talk a little bit about what it means, the whole idea of independent living, which I'll talk about in a bit, but also the implication and impact of the COVID pandemic on people like me. I am so empowered, in that way. I live in a big city. I have an independent source of income, which was not affected during the pandemic. I I live in a comfortable, in a middle class colony in Delhi. So, all those, I have access to mobility issues. I have the money to spend even if I can't drive. But even in that context, what did the pandemic do? And in terms of my location within the community, because eventually, we want to know a lot of these experiences that we are talking about. Yes, the pandemic created a lockdown. It did create unemployment. It did create all those kinds of implications for everybody. But what does it mean for people with disabilities is actually more we need to look at it more in the terms of community, because as it is on a normal basis, their reliance on community assistance, community help, and by community I'm even talking about neighborhood, I'm talking about the workspace, is more. There is a greater need for engagement with the community, for women with disabilities, for people with disabilities to lead successful or to lead comfortable lives. And I'm talking about this, that during this pandemic I myself felt so deprived at times, like the fact that there was no public transport. I needed medicines. The chemist shop in my area couldn't access those medicines because the factories were closed and those medicines were out of the market. So in terms of health status, as been mentioned, not only people with disabilities, but everybody suffered. You ignored minor problems. You couldn't go to hospitals. Sometimes you couldn't get medicines. So health issues with people with disabilities, and especially if there are people with disabilities who have comorbidities, this was not only an added risk factor for their health status, but also an added barrier in terms of accessing medical services. I know so many people who, just deferred going to the doctor because they just couldn't go. Even when the hospitals opened, they said that we don't want to go because the chances of infection are high in hospitals. So the lockdown itself created such a scenario where even very normal people refuse to go out. Now, if it's people with disabilities, they have to go out. At some point, life has to go on. You need to buy, you can't. Now, for example, if it's visual challenge, I'm not very, and due to also age, there is a digital inequality also. I'm not very comfortable with ordering online because I can't see properly. I can't enter my bank details properly. I have issues there, and hence I could not actually even access a lot of the online things, even though I had the online mechanism. So it's not only that you have the material resources, but because of your disability, you are deprived of their utilization. And I think the other thing which we need to, which really I think was a big thing that bothered me, was I was living alone in this community of middle class households, and nobody, I could die in that house, and during lockdown nobody would have known because everyone was locked down. And there was zilch communication with the neighborhood, zilch communication with any kind of, what you call it, the resident welfare society. So even in communities, and this is a common where Nandini talked about intersectionality. This is where gender and disability intersect. In my community where I live, nobody's thinking that here is a woman, even if they don't know about my disability, they're not thinking here is a single woman living alone and in a lockdown period. So, that basic human concern of normal people was also missing. And this has implications for people who are disabled and living alone, because you do need, who could I ask? I had no one in the neighborhood I could ask to get me a medicine. So I used to ask friends who would order online for me, and I got it delivered at some point. So I think, the pandemic and, lockdown was one aspect of the pandemic. The pandemic is still going on, and social distancing is still a measure that we have to, which we are told we need to follow. And for people with disabilities, now if someone's visually challenged and they're walking on the road and they need someone to help them cross the road, it's not so comfortable now to ask anybody and that person holds your hand and you cross the road. So, in terms of the basic, so coming to this, I feel independent living is to me, it's a very fraudulent term, because I don't think anybody's independent. I mean, no, everyone is interdependent, everyone is codependent. There is no independent living. I think the idea came up in the disability rights movement in terms of the oppression of institutions that was experienced by disabled people in the West. And then, of course, you can say the oppression of families. But there was at that time, in the West, this whole thing of after you're 20, you need to be independent. You need to live separately from your parents. You need to earn your livelihood. You need to be on your own. So that idea that normal people were living independently after a certain point from their biological families was something that I think got into the disability rights movement. But logically, I mean, who's independent? Can any of us? I mean, we can't be Robinson Crusoe. No, all of us depend on and if we begin counting, I don't think the disabled persons are any more dependent or independent than non-disabled persons. If non-disabled persons look at the way that their lives are codependent and coexistent with the lives and the functions that they perform in terms of and the functions of other people in their different life scenarios. So I think in terms of independent living, I think it's it's a non-issue in my view, but of course it's there in the UNCRPD. So we need to look at it in our context, and I think there are certain contexts where people are forced. I mean, I would say that many people who are living in hostels for the for the visually challenged and for the hearing impaired in terms of their education. I mean, in a way, that for them is a independent living in terms of their families, because they are managing many things, even though it's in a context of a special school or so. Still, it's independent from the family. Then many young people, when they come into the college system, they are living independently. Because living among non-disabled people, for disabled people to be able to survive, is a challenge, is in fact a kind of living independently, where you have to actually negotiate, create your support structures, create your support systems, and you are on your own. I mean, if in a college hostel, undergraduate college hostel, it really depends on the person who's disabled to be able to carry on his or her life in the way that she should or she can. So I am not very clear how I should talk about independent living in the context of the pandemic. But if you take my own example, I live independently, but I had, as I illustrated, 2-3 issues, so much issues with regard to actually managing my life. And this is apart from the sheer aloneness which disabled people often experience if they are living in non-disabled surroundings. I mean, here I was that my community didn't come forward to help me, but even otherwise, I mean, one only has to hear the story of hearing impaired people, how they are so lonely within their own families because of the lack of communication with their hearing family members. So I think the pandemic has thrown many challenges, and they are not, it has thrown challenges for everybody, and people with disabilities have been disproportionately affected by them. And I think the lockdown was one extreme form of the challenge, but I think the challenges continue on a day-to-day basis even now, and until one actually gets vaccinated. Not that a vaccine exists or it becomes available and it has high efficacy, but until we all get vaccinated, I think these challenges, many of them are going to be rare. In many cases, it's going to be more. When you go to the workplace, you're under so much stress, because how do you follow social distancing in a society like India? You can't. And if you're a disabled person, you do need assistance from others. You do need help. You do need to take the risk of proximity to another physical body, and you don't know the infection status of that particular person. So there is always this risk that people with disabilities, women with disabilities, have to take to carry on with their lives in the context of this pandemic far beyond the lockdown. I think I'll stop there. I'm sorry if I've diverted too much, but that's what I have to say. Thank you.
Thank you, Renu. Actually, I think it makes more sense what you say, because as I also mentioned, in India, the concept of independent living really doesn't exist for most people. So whether for disabled people, we are asking for a very different kind of a scenario. I think what we can really talk about is relative independence, one, and that would in a certain way look at, say, more infrastructural knocking off of the infrastructural barriers and creating the support systems that you were talking about, because the support systems are probably, and these could be community mechanisms which do not exist neither for the disabled nor for the elderly nor for the sick people who could access of these systems. And during the pandemic, I think it was even more impossible situation. I'll ask Nidhi now to talk about, please talk about violence against women with disabilities within families, which includes domestic violence, but also violence due to lack of access to sexual and reproductive health services. How did access to the entire range of services get affected by the domestic situation and the escalation of invisible violence during the pandemic? Nidhi?
Thank you so much, Nandini. And thank you, Reena and Renu, for really sort of diving deeper into the subject and experiences of women with disabilities. So most of the points that I will be presenting here are from a research study that Rising Flame, the organization that I'm heading, we did at Rising Flame in collaboration with Sight Savers India. It was a pan-India study, used the focus group methodology, and really went through or captured experiences of 92 persons, so 82 women with disabilities and 12 experts. We covered, or not really covered, but these respondents were from 19 states of the country and very, very divided between urban areas, small towns, and rural areas as well. It was, of course, conducted online, and conversations and all the discussions were online through Zoom and telephone. Now, what did we learn through this study? Globally, we've been speaking about the shadow pandemic, domestic violence as a shadow pandemic. And when the conversation started, UN came up with a statement in late March, early April, that domestic violence was globally, the incidence had increased, the rate had increased, the intensity had increased. Again, we saw that women with disabilities were not really as a key focus within that. In India, we had the comprehensive guidelines that our department, the Department of Empowerment of Persons with Disabilities, that they came up with. Again, there was no nuancing or specific issues that women with disabilities were facing. Of course, it was for all persons with disabilities, but there are certain specific challenges which are over and above, which are very gendered in nature, which are specific to women with disabilities. What really came clear from our report and the research that we did was that, and we know this pre-pandemic as well, it's not that experiences didn't exist before the pandemic. Of course, some of them were unique and some of them were exacerbated, but definitely to see heightened discrimination, access barriers, and access in terms of not just physical accessibility, because there was social distancing, and someone like me as well who's blind couldn't, who needed people who need tactile support, people who need to read lips with masks, access went for a toss. So it wasn't really just the infrastructure of physical access. We looked at digital access, informational access, access to health, access to food and essentials, social protection, and so on and so forth. The important thing was to see how all of these barriers were somehow linked to violence and emotional well-being of women with disabilities. And I'll lay out a few examples here. So first of all, out of the 82 women with disabilities, 72 faced access barriers in some form or the other. And why I'm emphasizing on access barriers, to link back to what Renu was saying about independent living. And we'll see that in the education sections of the report, in the employment sections of the report, in the digital access to barriers to accessing digital and informational pieces. A simple thing, right from, access something that the state should have provided, where the lockdown was announced on 24th March, if I'm getting the date correct. There wasn't any sign language interpreter when this announcement was done. Our deaf participants reported that the only information, so obviously everyone was very worried, everyone was trying to, get things in place, have these systems in place. So the only information they had from family, until sort of really deaf groups came up with statements in sign language, etc., that don't go out, otherwise you will die. And that was a restriction and a heightened space of fear. We don't know what to call this, right? How is this linkage that you deny access and you don't think a critical access response, a critical measure in the time of crisis, critical announcements, critical responses should be inclusive? And these are really structural violences that we could say, because this does not only say, okay, the one day the accommodation was missing and you're making a big deal out of it. This is about life and death. Really ranging from that to talking about access to health services. So in the lockdown, which is now no more the scenario, there were women with disabilities who could not access sanitary ware and sanitary napkins, right? Some of them could not go to the shop and get it because it's something that you don't order online, right? It's the sanitary napkin. There is a lot of shame. A lot of menstrual products have a lot of shame and taboo around them, surrounding them. So they could not order online. Or over the phone from the neighborhood chemist store. They probably did not have women folks in their families and only lived with the male folks in the family and were very too ashamed. For women in rural areas, they did not have sanitary ware at all. So they could reach the chemist stores, but there was no sanitary napkin available. In this scenario, women with limited mobility also had to use cloth, and they found it incredibly difficult to wash the cloth, maintain basic hygiene, because when you caregivers still agree to support you with your bathing, etc., it's very difficult to ask for care and assistance to wash a sanitary cloth which is used around menstruation. There have also been around sexual and reproductive health, particularly reports from the respondents from interiors of Rajasthan and other parts of the country that lady doctors within, and they're not even saying gynecologists, lady doctors are not available within rural areas. Besides the fact that it is difficult for persons with disabilities living with many comorbidities to access hospitals and services, because most of the hospitals have become COVID centers. And so our respondent also mentioned that for a simple back pain, which had grown very chronic, there was no means to access a doctor because in the village the doctor wasn't available. They were asked to go to the city. There was no public transport, and even now, accessing public transport and still maintaining hygiene and social distance is really a dream. And when you live with a disability, public transport is not accessible. They were daily wage workers, so they could not really go and hire private vehicles. So there was an economic constraint to do that. From here, combining some of the barriers to say what then happens when you can't access health services fully. For effective and full participation, so when we're also talking about independent living, many women with disabilities or women living with chronic illnesses and other health conditions need to access everything ranging from therapy, medical care, occupational therapy, physiotherapy, psychotherapy, and so on, simply to ensure that they are living independently, that they're fully and effectively able to participate within families, in their workspaces, and so on and so forth. And when we combine some of the things that Reena and Renu have shared, to say that how many women with disabilities really have private spaces where they could probably access online their psychotherapist sessions or continue therapy for their mental health. That was one. The second is how many of them can really survive if you take away the physiotherapy and occupational therapy that they had access to before, with sort of chronic pain, chronic illness, in many cases cerebral palsy, and so on and so forth. So there has been a lot of systematic and structural barriers which have caused these issues. But things around access, around employment, and around education, which really went into spaces of violence, around food and essentials and social security. And I will give you some examples of domestic violence here, which will narrate the story of how these linkages really work. First of all, how do we know how many women with disabilities are facing domestic violence during the pandemic? In our advocacy, we have been able to reach through to the National Commission for Women and encourage them that at least the complaints that they're getting, if they could really disaggregate it by disability, something that we have been advocating as group, as a Women with Disabilities India network, as individual women with disabilities, to have disaggregated data around crime against women with disabilities. And so this is something that hopefully the National Commission for Women, as per their commitment, will take up. But what we really found is numbers are missing. We only have narratives that we could capture. And what do these narratives say? There were cases that deaf women reported because they could not go and buy groceries um, because of the barrier of masks. And now nobody is here trying to say that, oh, take off your mask because it creates access. Here we're trying to present how a mask can hinder full participation or independent living of women with disabilities. So this deaf woman would work with lip reading and could not access it because of the masks that grocery vendors, etc., would wear. And because that did not work, the father became abusive, saying that you're now becoming a burden to me and this is not okay. Food and essentials and social protection. Many women in rural areas reported, and two cases here to share, that women with disabilities who are actually presented as not women enough, who are generally assumed to not being able to do household work, and so are not quote unquote perfect carers, and so not unquote perfect women, were really forced to do all the household work, and the essentials were withheld, saying that unless you finish this and take care of the family, we will not provide you with the food and essentials that you need. Similar with social protection, because they could not independently access their banks, where if at all the social protection schemes and amounts had come through. And I echo what Reena presented. In most cases, the 1,000 rupees announced by the central government for 3 months had not come through. Disability pensions were disrupted and delayed by months. Even if they came through, because they could not go to the bank, a family member or their husbands went to the bank with their signatures and had access to all their financials, rather than them being able to have independent agency over the finances that they'd received into their banks. For other women with disabilities, it was where something that you said, Nandini, where families just do not, or I think Renu mentioned, families do not know sign language. And so being locked down or being continuously at home is an experience of violence in of itself. It's not just the access to caregivers, but the access to communities of care, which is your disability community, which is your peer networks and groups, was a very, very deep violence experience. And I'd like to complicate a little bit more. I want to speak about queer persons with disabilities and those folks who had not outed themselves. This is an additional information, not from the report. Who had not outed themselves. It was extremely difficult and traumatic for them to be in their homophobic families. I will take a minute more to wrap up. I know we're coming close to the time, but we also had cases which is specific to women with disabilities around threats, around neglect, around isolation, around families abandoning because probably the male members had lost jobs. And so in some of the cases, the husbands became really, really violent because they could not handle the frustration of losing job and not having the money to spend or to earn. And in some other cases where there was already a pre-existing domestic violence case, and the woman had returned to her own family, the brothers threw her out and said, please go back to your abusive husband because we've lost our jobs, we're not earning enough in the pandemic, and we cannot support you in this space. So just to say that, again, women with disabilities are facing severe discrimination, violence, and abuse in this current moment. It is definitely, if we look at inclusion at the policy level, from where we're speaking about disaster risk reduction, or this pandemic, COVID was declared as a national disaster in the country. So what is a disaster management, and how many women with disabilities are specifically there in these committees at the state level, right? Thinking through, are the domestic violence policies or even the mechanisms that are being set up now, are they sensitive and inclusive of women with disabilities? Simple, are COVID and other health helplines, mental health helplines, violence related helplines, how are they accessible if they're just helplines? How are they accessible if they're only apps? how are they accessible overall? We know that women in this country, and this is not women with disabilities, there are many studies that say that women are not owners of digital devices, right? There is a huge discrimination, and hence we see one of the cases in the report that when it comes to education and parents in families where there's only one digital equipment, a non-disabled child is prioritized over the disabled child, and the male child with a disability is prioritized. Their studies are prioritized over this girl child with a disability because A, her studies are not important, her education isn't important, and B, she needs to do all the household work. So this complexity of gender and disability coming together at every stage, and therefore the strong need for an inclusive response at multiple levels. And here I would not say just the state. Of course, the state, because the state is responsible and is drafting the policies and is responding to the crisis and is supposed to be anchoring at the state level, at least with the disability commissioners, responding to people with disabilities and including them, but also as civil society, as people. What Renu outlined was something as people, right? And we've set up this for as peers. We always do this. We reach out to other people, friends with other disabilities or with the same disability, and say, "Hey, if you need help with this, I have someone who could help, and please just let us know," right? And so we're talking about multiple levels because COVID is something that has cut across caste, class, intersections. More or less, we're all impacted. It's complex in some cases, it's over and above in some cases, it's exacerbated and heightened in some cases, but we're all there in the same boat. And I think inclusion will be the key, at not just with disability and gender, but other marginalizations and vulnerabilities as well. Thank you.
Thank you, Nidhi. That was really a lot of information about the kind of violence that you have documented. Uh, Before, like I go into my final remarks, I think two things have come out very clearly. What Renu was highlighting in terms of doing research through digital devices, and the fact that Nidhi also pointed out the access to digital devices is limited, and often women, because they do not have privacy, the data they might be sharing with us might be limited in its scope itself, and not knowing the context, not knowing the situation in which they are sharing the information with us might bring in some biases. But having said that, at least both your studies show some of the issues that need to be really highlighted if we are talking about the pandemic and how it has affected lives of women with disabilities.
Nandini, can I just say one thing?
Yeah.
I'm sorry to interrupt. But I think it's really important because it's coming out from a range of other sources. I mean, if you read the newspaper columns these days, these counseling kind of help columns, lot of the problems across, I mean, non-disabled, disabled, everyone's talking about are the mental health issues coming out of specifically working and living from home. And I think in the context of disability, there's always been this thing that they can't travel, they can't commute, so society is not sensitive to their mobility needs. So provide as much as possible for them at home, provide them with education at home, provide them with work at home. And now this pandemic has clearly actually brought to the surface, one, that work from home, living from home, this kind of scenario produces huge, not only does it produce shadow epidemics of domestic violence, but interlinked with that, epidemics of mental health illness. And this is across the world, not only in our country, across the world it's coming up, especially in societies which value a lot of independent living. So, we're coming full circle. And the second thing I think is that if people, the so-called non-disabled, having so many mental health issues when it comes to a scenario of the lockdown and all, one can just imagine the plight of women and people with disabilities in this regard. So I think we want to bear this in mind, that there are huge mental health consequences of the pandemic on people with disabilities. I mean, when we think of disability, we think of, well, mental health issues, psychosocial disability, but no, I mean, on people who are just disabled in other ways without really being labeled as psychosocial disability, but the huge mental health burden in times of, for all the reasons enumerated in the earlier presentations, how it affects the mental and for people with disabilities, they really need to, in order to care, because the challenges are so many. If they are not mentally prepared for those challenges, then life is very difficult, because every day at times is a challenge, and you have to have the mental resilience to be able to cope with them. So I think this mental health dimension and disability also needs to be underscored.
Absolutely, Renu. Sorry, I'm also jumping in, Nandini. Thank you for bringing that up. I did say I'll drop the connections between violence and emotional well-being, and we called it emotional well-being for a reason, because that would also encompass mental health issues, but also just the emotional well-being of how and the impact that all of this isolation, the uncertainty, the fear, the heightened discrimination, having no access, right? And like you said, for women's safety, but also for independent living for people who did those things independently before. It all has a consequence on emotional well-being and mental health, and hence, even in the mental health response, as I said, accessing mental health services, online helplines, etc., and that really also becomes the responsibility of mental health, the first responders, but also within the communities, within civil societies, and so on. So thank you so much for bringing that up again and emphasizing.
Thank you, Nidhi. Actually, that is the point that I wanted to make here, is the fact that though we have a new Rights for Persons with Disabilities Act, which is in consonance, so to say, with the UNCRPD, we have many more proactive laws. We have the Criminal Law Amendment Act of 2013, which really brought in a lot of provisions so that disabled women could access justice. But we still find that there is this huge gap between what exists at the level of policy and what is there at the level of practices. So neither are the community level services inclusive, nor are they accessible, and none of them are responsive to the needs of women with disabilities. And here I will talk about rural women, women with psychosocial disabilities who used to access medicines from the PHC, couldn't access medicines for a very long period of time. So they had no support at all available to them. What I want to also highlight here is the fact that if you look at women and girls with disabilities, they themselves are a very heterogeneous group. So the needs of particular disabilities or particular kinds of impairments are also very different. So there needs to be adequate provisions and practices to address these multiple discriminations at all levels. I would like to also talk a little bit about the fact that, and what Renu was bringing up, this emotional well-being and resilience thing. I think girls with women with disabilities learn from their very childhood to become resilient, because they keep hearing very, very negative things about themselves. They are seen as burden, they are seen as dependent. In an Indian context, women themselves are never seen as very autonomous people. So questions of autonomy for a disabled woman itself is a misnomer. I mean, I don't think we can apply a question of autonomy for most women with disabilities in India. The other question is about family. The family, which is also the space for care and protection, often becomes the space where there's a lot of violence that happens, and everyday kind of violence in terms of denial of food, medicine, support for a lot of other things, but also other kinds of structural violence like denial of property rights, then denial of access to reproductive health and families. And that is one more thing that is very clearly evident in case of women with disabilities. And during the pandemic, I think there has been a lot of emotional violence at the site of the family. There has been, with all the people of the family staying at home for most of the time, the women with disabilities have been subjected to a lot of, I think, Nidhi, you were mentioning, a lot of comments about how incompetent they are, and how they are a burden, etc. The other point that I think is very clearly illustrated in one case that happened in Jaipur, and I think you will recall this case where this girl with disability was killed, sexually abused, and then murdered by her brother at the behest of the parents, because they wanted to dispose of a dependent member of the family during the lockdown. This was reported in many of the newspapers. So while this is one kind of violence that happened within the community, within the family, the other example that I would like to end with is a lot of disabled women who were working in Chennai was thrown out by the landlord because they lost their jobs and couldn't pay the rent anymore. So overnight, the landlord asked them to leave. So this is the kind of vulnerability that we see among women with disabilities in terms of how they, excuse me, sir, how they are dealt with, and the pandemic has actually exacerbated this kind of violence, as we have said. So I think what we really need to look at policies that are there, and then maybe move for better policies. And Nidhi, you rightly pointed out how do we look at disaster management policy and how we bring it to the pandemic situation. And along with it, I think we need to really engage at the practice level to see that these policies are implemented properly so that women with disabilities have access to a lot of support. I will bring this discussion to an end here. If anyone wants to add something, or I will end the discussion here. Thank you. Thank you to everybody, Renu, Nidhi, Reena, for a very stimulating discussion.
Thank you, everyone, and namaste.